All right, move this thing out of the way. Okay. Good morning. I'm Martin Brown, one of the neuromuscular doctors here at UofL, and I'm going to be talking about a sort of a challenging topic about a challenging disease. This is sort of I kind of bit off more than I could chew here, but I'm going to at least share with you what I've learned when trying to review this disease and kind of update myself about it. I don't have any disclosures relevant to this talk, and none of the treatments that are discussed here are FDA approved. And those are my disclosures. So the objectives today, I want to review the different manifestations of this disease. Multiple systems are involved, and many of those problems are not really usually managed by neurology, but you need to at least recognize that these might be a concern and you might require some help when you're managing these patients. And then I'll briefly touch on the genetics and how the genetics contribute to the pathophysiology. And then we'll kind of cover the management of this disease, which is always involves multiple disciplines, and you will appreciate having someone who is very familiar with this disease. You will want to have, for example, you'll want to have a cardiologist, ideally electrophysiologist, who really sees all of your patients, all of your myotonic dystrophy patients, because they have specific needs that, and they're complicated enough and they're diverse enough that you'll want someone who is familiar with when things are getting dangerous or what needs to be managed or watched more closely. So we'll start by going over the disease epidemiology, and most of the talk is actually going to be about the clinical presentation, because this is something that this is a disease that could be so obvious that the diagnosis is made within a handshake or within the first couple minutes you enter the room. And sometimes it is something that is not recognized until sometimes after the fact, after the patient has maybe died from sudden cardiac death or at a very old age, at an advanced age, in a very mild case. It can present somewhat differently. I will apologize to the pediatrics group. I'm not going to be presenting a case or a description, much of a description of congenital myotonic dystrophy. This is sort of myotonic dystrophy, mostly adult presentations. We'll also cover the genetics and the pathophysiology, and then briefly go over the management and some of the therapeutic targets that are being looked at. But most of the talk is going to be about what does this disease look like, how does it present, what other problems can occur with this disease. So this disease was described by Hans Steinert. It was called Steinert's disease for a while. There had actually been several cases, individual cases that had been reported before, but no one sort of put all the pieces together because it had a varied presentation. And so Steinert described 6 cases. A couple of them were related. They all seemed to have this progressive muscle stiffness. They had this distally predominant weakness and atrophy, and that also involved the face and the eyes and the tongue. And then he used something that Duchenne used 20, 30 years before him, the little galvanic stimulator to directly stimulate the muscles. And when he would shock the muscles, they would contract, and they would take a little longer time to relax after the stimulation. And so that was the first sort of electrical demonstration of myotonia. So myotonic dystrophy is worldwide, it's the most prevalent muscular dystrophy, even in kids. Now, if you only count boys, then and in childhood, Duchenne becomes the most common if you're only looking at the population of boys in childhood. But otherwise, myotonic dystrophy is the most common. And it's not the most common everywhere. In some places, it's very rare. There are little pockets of AN where it's very rare, and there are places in like Iceland and northeastern Quebec where it's very common. But the prevalent studies are somewhere between half per 100,000 up to 18 per 100,000. It equals affects males and females equally. It's higher in Europe and South Africa, and lower in sub-Saharan South Africa. And then again, there are these pockets where there's a higher incidence or a higher prevalence, probably related to founder effect. And if you and this is just from earlier this year, a newborn screening program was used as a sample or samples to gather samples, and it turns out that there are more people who have what would be considered a pathologic expansion, repeat expansion, anything greater than 50 repeats, CTG repeats, would qualify as the diagnosis of myotonic dystrophy, and then about 4 times that had the what's called a premutation, which is anything more than 35, 34 is considered a premutation, up to 49, meaning that you have the potential to pass this disease on. You're sort of a carrier. You're a carrier, basically, even though it's an autosomal dominant disease. The premutation is sort of like a carrier state, and some of these carriers can have symptoms. That's one of the milder end of the spectrum of disease are people in their 60s or 70s who develop cardiac arrhythmias, and it's possible that their premutation state is responsible for that. So there's a genetic prevalence and there's a clinical prevalence. The clinical prevalence, you identify these patients and you count how many of them there are. In that study, and that newborn screening program gave us a genetic prevalence. And so there's a big difference between how many people should have the disease based on the genetics and how many people are recognized to have the disease. And that could be from a widely variable clinical presentation where some patients are, the disease is so severe that it is lethal, and then some people are asymptomatic well into their 70s, 60s, 70s. The onset of the disease could be at birth with congenital myotonic dystrophy, and then some people are asymptomatic until late adulthood, and sometimes these patients. So as a neurologist, I say, well, it's because they just didn't get referred to me, but that's not always going to fix the problem. But they might not get referred to a neurologist, and the diagnosis might not be recognized for one reason or another. And then if they are referred to a neurologist, some of them have these symptoms that are not sometimes less desirable, not desirable. Symptoms like fatigue and hypersomnolence and myalgias and fog, brain fog, and those are symptoms that will sometimes get them out of the neurologist's office prematurely. So the systems that are involved are muscles, but it's much more than a myopathy. It's a disease that affects the heart, and not so much it does not really cause a cardiomyopathy as much as it causes an electrical problem of the heart. And if you think of myotonia and grip myotonia and percussion myotonia and myotonic discharges and that vein contraction that Steiner noticed, if you think of if that happened in the heart, imagine what that would do to the heart rhythm. If a muscle cell just grabbed and held on and didn't relax, that could be a problem. So cardiac induction problems are very common. Pulmonary issues are the number one cause of death in myotonic dystrophy, often from aspiration pneumonias. Ocular problems include cataracts, and there might be a family history. There might not be a family history of any type of muscle disease, any type of myotonic dystrophy, but mom had or dad had cataracts in their 40s or 50s at an age. And that is sometimes the only hint of a family history. GI symptoms are probably also related to the muscle contractility and ability to relax, and so the smooth muscle is also affected. This is a brain disease as well. Myotonic dystrophy affects the brain, and it affects cognition. It affects there are psychiatric effects, and there are definitely effects on sleep and somnolence, hypersomnolence, fatigue. There are endocrine problems, and then there are even there's predisposition towards certain types of cancers. So lots of different systems are involved. What we deal with and what we should be able to recognize, this could be one of those walk in the room and make a diagnosis just at first glance. It's weakness in a unusual distribution for muscle. For myopathy, we normally think of proximal symmetric weakness, and this weakness usually starts distally with foot drop or with weakness of grip, and it affects facial muscles. There might be a decreased ability to raise the eyebrows. There might be ptosis. There might be weakness of, there could be slurred speech and trouble swallowing from weakness of the muscles that help you speak and swallow. And then also there might be difficulty producing an effective cough because of weakness of these muscles. There is often weakness of neck flexors more than extensors. And then there's weakness of the diaphragm, there's weakness of the chest wall, and the respiratory muscle weakness is, again, probably the reason for the most common cause of mortality is from pulmonary occasions. And then, I didn't say myotonia on here, but myotonia and myalgias. Myotonia, I think we're going to see on the next screen. Wait a minute. Oh, yeah, so beware of YouTube. If you go on YouTube and you look for examples of myotonia and look for examples of myotonic discharges, you will see a lot of, there's some of that, some of the stuff on YouTube is not accurate, believe it or not. Not everything on the web is good information. So more information is not necessarily good information. But I did, despite that, I was able to find a good case of grip myotonia, and so you can do this without even, you can do this by telehealth. You can ask the patient to make a tight fist, tight, and then ask them to relax quickly. And if you do that, it doesn't take a second. And we'll watch what happens when this patient is asked to squeeze or squeezing the fingers and then ask them to relax. And it's like the wrist extensors will relax kind of soon, and then it takes some time for the rest of the flexor compartment seems to have trouble relaxing. And that's actually a common thing, that when people relax, their hands will kind of do this first before they're able to, they'll often straighten their fingers out because they've experienced this before and it's not very pleasant. So those are the muscle manifestations. The cardiac manifestations are mostly related to conduction problems. So there might be tachyarrhythmias. There might be symptomatic. There might be bradycardia, which is sometimes symptomatic. Atrial fibrillation is common, and other type of ventricular problems, dysynchrony. And then there is sometimes a cardiomyopathy. There can be systolic dysfunction, left ventricular systolic dysfunction, and sometimes the initial manifestation or a manifestation of myotonic dystrophy is sudden cardiac death. Pulmonary function is affected from from weakness of the diaphragm, weakness of the chest wall. There might be trouble with swallowing safely, so aspiration is common. And if there is aspiration, sometimes the cough is not effective. There are problems with hypoventilation from weakness of the diaphragm and from just inadequate pulmonary function, respiratory muscle function. Central sleep apnea is a common problem with myotonic dystrophy, and then obstructive sleep apnea, the regular, the ordinary run-of-the-mill obstructive sleep apnea is also a common problem. Also, pulmonary functions, under pulmonary functions, I put the complications with surgery. So if a patient with myotonic dystrophy is going to have a surgery, it is important, just like what we tell our patients with myasthenia, tell the anesthesiologist that you have this. This is a good idea for anyone who has myotonic dystrophy who's getting surgery. They should make it clear to the anesthesiologist that they have myotonic dystrophy, and there's actually a packet that is made by the Myotonic Dystrophy Foundation. It is targeted. It is prepared for anesthesiologists who are going to be doing sedation and intubation and things like that. And it is a source of complications with this disease. The ocular manifestations of myotonic dystrophy include these things that are called Christmas tree cataracts, which that doesn't look like a great Christmas tree, I guess, if you squint and look back a little bit. But there are these iridescent posterior subcapsular cataracts, which are unusually early onset, like in the 40s or 50s, or even earlier for patients who have a more severe form of myotonic dystrophy. Patients will also have ptosis, and they might have their eyes might open when they're asleep, which can cause other complications, corneal problems, if the eyes are not able to close tightly, or, and some people have myotonia that affects the eyes, and if they sneeze while they're driving, their eyes will sometimes close, and then they will have a hard time opening their eyes after they sneeze. And so if you're driving and you have eye closure myotonia, that could be a problem. The manifestations, gastrointestinal manifestations, are start with swallowing. There's dysmotility, not just oropharyngeal problems, but the esophagus itself is a muscle, and the esophagus is also affected sometimes. So there can be esophageal dysphagia, which would be more problems with solids than liquids. So myotonic dystrophy can cause problems with either solids or liquids or both. Patients can get these pseudo-obstructions. They can have IBS-like complaints that also might you might want to you have to back off, and this is still your patient. You just have to find someone who manages IBS or is comfortable managing that. Gallstones are more common. It might be related to problems with the sphincter. And then these patients have sort of unexplained elevation in liver enzymes, and they really are liver enzymes because the GGT is truly a liver enzyme, and that is also elevated. It's a mild elevation, and it's not from CPK, because CPK can come down and CPK can normalize, and these liver enzymes might remain elevated even with a normal CK. The neuropsychiatric manifestations, so cognitive impairment is very common with congenital myotonic dystrophy, and then with milder cases of myotonic dystrophy, it can be a minor problem, or it could sometimes be the only problem if you have a patient with a very mild form of myotonic dystrophy. They could have a late onset or a sort of an early onset dementia, basically, and it can be the manifestation of myotonic dystrophy. So if you're seeing patients for cognitive impairment and you happen to notice that they have a frontal balding or ptosis or maybe some speech trouble or anything else, or grip myotonia, that might be a clue. Apathy is a major problem, and it's more than just what is related to lack of facial expression. The same thing, something similar happens in patients with Parkinson's, where they appear to be apathetic because they have really very little facial expression. And the same thing can occur with myotonic dystrophy, but it actually is, they do have apathy. And there's going to be a case here in a second of a patient who used to be sort of a type A personality, and he just gradually turned into, he had no emotions whatsoever. And sometimes the apathy and the sort of the dull appearance will look like someone has cognitive impairment even if they don't. And then the hypersomnia and fatigue, chronic daytime somnolence, that is sometimes the number one complaint of patients with myotonic dystrophy. And then they have a variety of personality disorders, or a variety of personality disorders are more common in myotonic dystrophy than in the general population. The endocrine and metabolic manifestations, insulin resistance, thyroid, males will have hypogonadism. Sometimes there's problems with calcium regulation. And then the skin, there are certain types of skin cancers, and I tried to figure out the difference between a pilomatrixoma and an epithelioma. and I wasn't able to figure out the difference, but if one of your myotonic dystrophy notices a lump somewhere, especially on the scalp, it wouldn't be a bad idea to get them checked out by a dermatologist or a plastic surgeon or someone who can kind of look at that and figure out, is it something that needs to be removed or biopsied. Excuse me. So here's the case. Here is a pretty classic presentation. This is a veteran who had a weakness that started in his, I guess, 40s, 30s, or late 40s, late 30s or 40s, and it gradually got worse. It was distal. It was foot drop and grip. He had grip myotonia. He described grip myotonia. He also described what sounded like tongue myotonia. He had, for the past few years, he had ptosis bilaterally. In his mid-40s, he had a syncopal episode and was evaluated for that, and he was found to have atrial fibrillation. And then he had an older brother who died suddenly for uncertain reasons, which is a little suspicious in a hereditary disease that affects the heart and can cause ventricular fibrillation. He had cataract surgery in his 50s, and then there are multiple family members who had the same cataract at a younger than expected age. He's had a couple of episodes. He's had dysphagia and possibly a couple of episodes of aspiration pneumonia. And his wife says that he had a serious type A personality until about 25 years ago, and since then he has just had he just didn't really have a care in the world. And he's had trouble with fatigue, chronic fatigue. He's had this sleep disorder, which hasn't really been characterized. So this to me was like, I thought this was a slam dunk, and so I sent genetic testing. Oh wait, actually before I did that, of course I did it. Actually, to be honest, I did the genetic testing, and when that didn't give me an answer, I did the EMG, and I don't know if this will work. All right, could you hear that?
No, we could not, sir.
Well, one more time. Did anyone get any audio from that? If not, I'll do it. I'll do a demonstration for you.
We did not get any audio. No.
Okay. Well, it sounds like it has been compared to a dive bomber. The dive bomber is buzzing along, and then it goes up and goes down. So the dive bomber, the pitch increases and the volume increases, and then the pitch and the volume decrease. So it goes, then if it happens, sometimes they're really fast, and it sounds like one of those European motorcycle races where they're all revving their bike. And they're often widespread. Like you hear one in the foreground and one in the background, and they're overlapping. And when you look at the grip myotonia, you can sort of imagine that this is what's going on inside of the muscle when the patient is trying to relax their grip. So much for that. So the genetic testing was sent through a company, PerkinElmer. PerkinElmer was selected because their muscular dystrophy panel included the two things I was most interested in. The one thing I was most interested in is the DMPK gene, and the second one was the CNBP gene, which is associated with type 2 myotonic dystrophy, which is called proximal myotonic myopathy. His was distal, and so I was more interested in type 1 DMPK gene. And it actually didn't show, the genetic testing did not reveal a variant in the DMPK gene. It did find something in a gene associated with autosomal recessive disorders, and if you do enough genetic testing, you're going to get these variants of uncertain significance. Sometimes they're likely pathogenic, but even when they're likely pathogenic, if your patient is symptomatic and the likely pathogenic gene is heterozygous for an autosomal recessive disease, it's not the answer. The heterozygous compound heterozygous can cause an autosomal recessive disease, but he had a heterozygous variant in an autosomal recessive gene, and so that was clearly not the answer. So it turns out that there's this fine print, and if you read the fine print in the genetic testing section, you'll see that they don't detect repeat expansions, and actually none of the Invitae, PerkinElmer, none of these will test for repeat expansion disorders in neuromuscular problems like myotonic dystrophy type 1 and type 2. Kennedy's disease is not tested. C9 gene that repeats in C9 or F72 are not tested. Friedreich's. Same thing for if you're looking for free testing for Huntington's, don't look here. And many of the spinocerebellar ataxias are repeat expansion disorders. So the test that for this disease, the test that was recommended to me from genetics is done through a place called St. Francis Center for Genetics, and they have to do a PCR followed by a Southern blot, which is something that the Invitae and PerkinElmer, those are automated sequencing panels that will only check for variant in sequence or sometimes change in copy number. Copy number means exons, copies of exons. Sometimes like PMP22 can be either deleted or can be duplicated, but that's an exon. This is not even this gene. This repeat expansion is not even in an expressed part of it's in the untranslated 3' region. So anyway, you need to use PCR followed by Southern blot. And the best way to do this is to refer the patient to Norton. Norton Lab will bill St. Francis using institutional billing. And so the bill comes back to Norton, and then Norton will charge insurance, whatever insurance will pay, and the charge will not go to your patient according to someone in genetics. This is the way to get patients tested. So we're pretty good on time. So the genetics of this disease and the pathophysiology are sort of intertwined. The DMPK gene, dystrophia myotonica protein kinase, the gene is located on chromosome 19, and in the 3' end There's an untranslated region that has repeats, and normally there are 5 to 34 repeats, CTG repeats, and if there are more than 34 CTG repeats, they are considered unstable, and there's something called expansion or contraction, and it has to do with DNA. When DNA is being replicated, sometimes the mechanism that is replicating will slip, and there will be an extra set put in, and then another 3 nucleotides will be put in. The CTG repeats can be expanded, and they can contract. If that expansion happens in mitosis, so this repeat expansion can increase in tissues after, in patients who have myotonic dystrophy. In certain tissues, the expansion can actually get longer. Like if you were able to count the CTG repeats in muscle and in the heart and in the gut and in the skin, you would find that there is this mosaicism where some tissues have a higher number of repeats and some have a lower number of repeats. So you start with, what you're born with, but at some tissues the expansion can increase and sort of the problem can get worse. So if there's repeat expansions in mitosis, then that can occur where you have somatic mosaicism. And if the repeat expansion occurs during meiosis, you can have what's called anticipation, where the offspring has a longer repeat length than the mother or father. So the number of repeats is directly related to the severity of the disease. So if you have 35 to 49 repeats, you normally don't have any symptoms, but you are sort of, you could be considered a carrier. And if you have 50 to 100 repeats, you have either mild or asymptomatic myotonic dystrophy. If you have 100 to 1,000 repeats or something like that, it's more like classic myotonic dystrophy. And then these huge numbers, these really high repeats, are the cause for congenital myotonic dystrophy. And so this is kind of interesting to me. So most of the time, congenital myotonic dystrophy is from mom. Mom is the carrier or has the premutation, or sometimes mom has a known diagnosis. And this is the clinical presentation or the test question that you might get will be question about a floppy baby. You have a hypotonic infant, and you go and you meet mom and you shake her hand and she can't let go, and that's all the information you get. And you should be able to give the diagnosis based on that presentation. Sometimes that can occur. Sometimes dad transmits the disease and congenital myotonic dystrophy sometimes comes from dad, but most of the time it's from mom. Now, in the older ages, so the classic adult form and the juvenile form of myotonic dystrophy and the late onset form of myotonic dystrophy is most commonly from dad instead of mom. And the severity gets milder as the onset is delayed, and as the number of repeats goes down, the severity is milder. So the genetic anticipation doesn't happen with all nucleotide repeat expansion disorders. Or at least if it does, it hasn't been confirmed that it happens with. It definitely happens with Huntington's. That is something that everyone's familiar with. It definitely happens with myotonic dystrophy. So the higher number of repeats leads to a younger age of onset and a more severe phenotype. And then it's not clear. I wasn't really able to find out how this hyper anticipation occurs, where a mom who might be in the presynaptic or presymptomatic range might just be she might have 50 or 40 repeats, and she transmits. She has a kid with 9,000, trying to try 9,000 repeats. So that is called hyperanticipation, and that is something that seems to be unique for myotonic dystrophy. So the way that the gene causes the disease is also kind of puzzling. The gene, so autosomal dominant diseases normally cause a toxic gain of function, and you think of, what does this protein do? What does this gene do that causes this disease? Well, this gene actually doesn't have the mutated gene, or the gene itself, the DMPK gene actually doesn't cause a lot of the pathology of this disease. What happens is there is something called alternative splicing, which is a way that your cells in one part of the body, in one tissue type, will express different proteins from the same gene. You can express different proteins in the muscle from the ones that you express in the brain or in other tissues, and that is accomplished through something called alternative splicing, where this exon is spliced out in this tissue and this exon is not spliced out in that tissue. And so you can modify it's called the transcriptome. So a single gene can produce different isoforms of a protein in this tissue from that tissue, and in the same tissue, the splicing mechanism, this transcriptome, can change with age. So you're supposed to, as in neonatal stage, you're supposed to express these proteins, isoforms, and then in older age, the isoforms are supposed to be slightly different. And so the transcriptome varies between cells, varies between tissues, and varies between ages. And so, for example, in myotonic dystrophy, there is a RNA binding protein called muscleblind, MBNL1, which is this yellow one. And I forget the name of this other one, but there's another one that is in early neonatal development, one of these RNA binding proteins does most of the controls the transcriptome. It stays in the nucleus while the muscleblind stays in the cytoplasm. And then later on in development, the muscleblind moves into the nucleus and does more of the controlling the transcriptome, which isoforms of each protein is going to be expressed. And the other gene, the CELF protein, that RNA binding protein, goes out into the cytoplasm. And one explanation for what happens in myotonic dystrophy is when these trinucleotide repeats are expanded and expanded and expanded, the transcript can actually fold over on itself and sort of bind with itself and create these hairpin turns, and it can create all these multiple hairpin turns. And it creates a whole bunch of binding sites for this, in this case, for muscleblind. So all of the muscleblind that's supposed to be controlling the transcriptome, it's all bound up on this expanded DMPK, all these hairpins. So the muscleblind gets consumed, kind of, and then this other RNA binding protein is now doing more of the work, controlling the transcriptome a little bit more, and actually creating what should have been a prenatal or a early developmental pattern or an early developmental transcriptome, rather than the adult, what should be happening with the transcriptome. So in some senses, this disease is called a spliceopathy. The alternative splicing mechanism is messed up by these trinucleotide repeat expansions, and that's sort of what this graphic shows, is that the muscleblind is all consumed, and so muscleblind is depleted, and then this other RNA binding protein is increased, and instead of creating a protein that looks like this, which is normal at this age in this tissue, sometimes you have a protein that is formed that looks like this. And this problem, this can affect these tissues in the brain, tissues in the heart. All of these genes are affected by muscleblind and other RNA binding proteins, and these are the tissues that are affected by this disease. So that's kind of the genetics of myotonic dystrophy. The PTG repeats create excessive binding sites, deplete the muscleblind, alters the transcriptome, and so you not only have a toxic gain of function, you have a toxic loss of function, and you have this aberrant protein expression, and that's the genetics of myotonic dystrophy. So what are you supposed to do for these patients? It's good to start with genetic counseling. We try to do what we can to maintain function and independence. We try and anticipate and ideally prevent cardiopulmonary complications, and then we try and manage some of the symptoms if we can. So the mobility and independence has a lot to do with weakness, and so when you're seeing a patient with myotonic dystrophy or pretty much any neuromuscular disorders that causes balance or weakness problems, ask about falls and trouble with mobility, and ask, you got up this morning, you got yourself out of bed. When you got up this morning, you had to get out of bed, get in and out, on and off the toilet, in and out of the shower, get dressed. Did you do all that on your own? Did you need any help with any of that? Or were you able to do it all on your own? Did it take a normal amount of time, or did it take twice as long as it normally does? Then when you were trying to leave the house, do you have steps to get in or out of your house? Do you have stairs to get to the bathroom, which is a bad idea? Did you have do you have everything on one level in your home? Because if mobility is declining, you will want to make sure that you eliminate some sources of falls. We also try and ask about problems with myotonia, because myotonia is something that we can manage or try to manage. This one doesn't have any audio, so it doesn't matter that you can't hear it. So he's gripping tightly, gripping, and then relax, and he can't quite get the fingers to straighten out without kind of smashing them against his thigh. So that's grip myotonia. Whoops. So this used to be treated with things like other sodium channel blockers like dilantin and carbamazepine, but mexiletine seems to work pretty well. It is similar to lidocaine. It's an antiarrhythmic. And the way that mexiletine works is the voltage-gated sodium channels have an activation state, and then they have inactivated state, and the lidocaine or the mexiletine will bind to that voltage-gated sodium channel. NAV 1.5 and NAV 1.7 are voltage-gated sodium channels that are expressed in the cardiac muscle and skeletal muscle. Mexiletine binds to the inactivated state and just prolongs it, keeps it in that state for a little bit longer. It doesn't prevent it from activating or firing, but if it doesn't prevent depolarization, it slows repolarization. If your patient already has some cardiac symptoms or has an abnormal EKG, you should probably get cardiology clearance before you start this medicine. This is from that trial. The normal patient, if you ask them to relax within 0.3 seconds, they can relax all the way. And this column B B is the patient with myotonic dystrophy, where you say relax, and it takes 3.75 seconds to completely relax. And then if they are taking mexiletine, they can relax in a quarter of a second. That's one of the treatments for myotonia. There are other ones, but that's probably the one to start with. You should be monitoring for arrhythmias. Cardiac complications are common and they are dangerous. So we'll get, if anyone has an episode, a syncope episode, they report palpitations, you need to ask about palpitations. You need to ask about syncope or pre-syncope. If they should be getting an EKG every 2 years, and if they have a heart rate less than 50, they have bradycardia. If they have a PR interval, either 200 milliseconds or it is trending in that direction, or a QRS duration of 100 milliseconds, or that's trending in that direction. If there's a anterior or posterior fascicular block, left anterior or posterior fascicular block, Q waves, any of these things should be evaluated by an electrophysiologist. For swallowing function, ask about trouble swallowing, choking during a meal, coughing after a meal. Sometimes your question is asked of the patient, and sometimes any coughing after a meal, ask the caregiver or the family member, do you have any choking during a meal? Does he have any coughing after a meal? Have you had any pneumonias since your last visit? Have you been losing weight that is not due to, something explained? Does it take you longer to finish a meal? Do you ever have to stop during a meal to rest? Or do you ever have to stop eating a meal just because you're taking too long and the family's waiting for you? You're at a restaurant and you're the last one at the table and you just stop eating, not because you're full, but because it just took too long. And is eating still something you enjoy, or is eating becoming something that is stressful or dangerous or exhausting? Those are people who, in the right setting, you may wish to discuss a feeding tube or PEG. For pulmonary function, you should ask symptoms of hyperventilation. Do you wake up with a headache? Do you wake up just not feeling refreshed? Do you have excessive yawning during the day, or just falling asleep, nodding off during the day? Or you can ask the family member, caregiver, spouse, if they snore and if they stop breathing in their sleep. And then you can ask the patient, have you started using extra pillows because of trouble sleeping when you lay flat? Or have you started sleeping in a recliner because you can't breathe, you're not comfortable laying flat all the way? So orthopnea. And I will often just screen patients with an overnight capnography, because we can get these done in the patient's home without doing a full-blown sleep study. And you can actually get someone started on non-invasive ventilation with a neuromuscular diagnosis and an end-tidal CO2 that goes above 45 or something. There's a number. Oximetry doesn't help you. Oximetry won't tell you what's going on as far as ventilation. If oximetry is abnormal without a problem without hypercapnia, hypoxia without hypercapnia is not a neurology problem. You should not be managing hypoxia without hypercapnia. Hypoxia without hypercapnia, there's a problem in the lung, not a neurologic problem. When you do pulmonary, you should be getting pulmonary function testing and make sure that there is a MIP and a MEP included on that, which is how strong are you able to breathe in and how strong is your cough, how well can you clear your airway. And we always encourage the annual flu shot and pneumovax and now COVID. There's a handout prepared by the Myotonic Dystrophy Foundation, which is, if someone's going to have a surgery, you can tell them to get a copy of this and give it to their anesthesiologist. And you're not telling the anesthesiologist what they don't know. You're letting the patient tell the anesthesiologist what they don't know and what they need to be aware of. If someone with myotonic dystrophy is having a procedure, they should know about these complications. Genetic counseling, I'm running out of time. So genetic counseling, definitely for anyone of reproductive age. And there can be complications during labor. So that same reference guide that's used for anesthesia can be shared with the obstetrician. There are a series of consensus-based care recommendations. These are published in literature, but they're also available free downloads from Myotonic Dystrophy Foundation. They have a whole series of them for adults, for kids, in German, in English, in French, in French Canadian, in Canadian French. They have it in several languages. They have all these toolkits. They have really useful information for physical therapists and occupational therapists who are working with patients with myotonic dystrophy. They do a lot of, they sponsor a lot of research. They do a lot of education. They do a lot of advocacy. So this is a good group. And because I'm almost out of time, and because I really don't know the treatment strategies, there aren't any here. If you want to treat a genetic disease, you can either target the DNA, you can target the RNA, you can target the RNA binding proteins that affect the transcriptome, or you can target each protein product individually. And so far, none of those have been accomplished. There are early phase treatments or interventions that haven't made it yet to even a phase 3 trial yet. But we can treat the hypersomnolence and myotonia endocrinopathies. Those can be treated. The disease-modifying treatments are almost all in this early preclinical phase, and a few things are just barely getting close to maybe becoming ready for prime time. So, myotonic dystrophy, the most common form of muscular dystrophy. It is a multi-system disorder, not just a myopathy. It is autosomal dominant. It is autosomal dominant with carriers, if that makes sense. It's a trinucleotide repeat expansion disorder, and the problem is that the alternative splicing mechanism is affected, and the transcriptome is altered, and most of our management is supportive and anticipatory, and there's hopefully going to be some treatments in the near future, but we'll just have to wait. Have any questions? Oh, these are the here's a list of all the nucleotide repeat expansion disorders and where they are. So myotonic dystrophy is right here on the 3' end. So you have exons, you have introns, you have exons. Introns are between the exons, and you have this end. And where's Huntington's? Huntington's is over here. EPLA, ALS FTDs, and a lot of neuromuscular and movement disorders in all the repeat expansion disorders. Most of them have to do with either neuromuscular or movement disorders. Curious. And there's some epilepsies. Sorry, the epilepsies aren't on here. I'm still talking. Are there any questions?
Why do you think there are so many movement and neuromuscular disorders that have trinucleotide repeats as their etiology?
Or why do trinucleotide repeats preferentially affect the nervous system and the neuromuscular system? I don't know. Maybe other people aren't paying attention. I don't know. It is interesting. Well, so the expansions, I'm not sure, but I suspect that these expansions, they're unstable. No, I don't really have a good answer. The expansions will continue to expand in someone's lifetime, but that really doesn't make any, I don't know. I have no answer.
I was kind of wondering, because that was part of my other question, was about, I'd never heard of the somatic mosaicism aspect to the trinucleotide repeats. I just had never thought about it in the way that it can affect preferentially certain muscles, maybe certain areas with higher turnover and mitosis. So I was curious if that could play into this.
Well, so we think of the brain and neurons as postmitotic, being postmitotic, and they are for the most part, and yet this somehow can occur with like FTD, ALS, the C9 expansion, that is in neurons. So somewhere there's this DNA slippage. Some of the problem with these nucleotide repeat expansions are the DNA repair mechanisms are defective, and that allows these expansions to occur because normally they're snipped out and cleaned up, and sometimes the underlying cause is maybe the DNA repair mechanism is defective, and then you have, this is how it manifests. But that doesn't answer your question, and I'm not going to be able to answer your question either. So I'm sorry.
It was more of a, conversation starter.
Isn't it curious? Yes, it is. It is curiosity. That's interesting.
Thank you.
You're welcome. Are there any other? I'm going to stop sharing. Oh, wait. Okay. So there's a chat going on. Let's see. What did I miss?
One of those was me, and we kind of already talked about it.
Okay. Do all diseases genetic anticipation? Oh, that's you. Okay. Okay. That means my time is up. Any other questions?
Thanks again.
All right. Thank you.